All right, everybody. Thanks for tuning in. We had some great presenters today. Thanks for moderating, everyone. So I'm going to start off with the chief complaint. So there is some history, but the chief complaint coming in is we have a 19-year-old female who presented from the student health clinic for workup of tachycardia. So brief HPI. So we have a 19-year-old female, no significant past medical history. She's a Columbia student. She was seen at St. Luke's. She came into this health center for persistent tachycardia. She, some background before she presented was a week prior. She was swimming. She's a relatively healthy, fit young woman. She swims for about 30 minutes. 3 or 4 times a week. And after this one swim, she noticed some palpitations that resolved spontaneously, but she told her parents, and her parents were adamant that she went to the student health clinic. So she went to the clinic, was tachycardic there, sent to St. Luke's for further workup. When she was at Luke's, she really didn't have many complaints. When we kind of went into more of a history, she did note that she hadn't had her period for 4 to 5 months. She presented in January of 2022. She reported feeling a little more stressed recently, which she attributed to being in college. She didn't use any illicit drugs, no new health supplements, and no food insecurity or history of an eating disorder. A little background on her: she's from China. Family history is significant for a hyperactive thyroid in the mom, but no family history of sudden cardiac death, autoimmune conditions. She's vaccinated for COVID with the Pfizer vaccine, and hasn't had a recent illness. So I know this is early, but does anyone have any thoughts or questions that they want to explore in this case?
How is her caffeine consumption?
Her caffeine? She drinks coffee here and there, but at most like 1 to 2 cups when she's studying a week.
Any other hyperthyroidism like symptoms like nervousness, diarrhea, sweating, weight loss?
No sweating, no diarrhea, no hair loss, no disturbances in her sleep. Got some questions. No prior episodes of palpitations. She only had the one episode of tachycardia, or she hasn't noticed palpitations before or a racing heart. This was kind of almost incidental when she went to the clinic at Columbia. No family history of arrhythmia.
Any recent viral infection?
No recent viral infection. No herbal meds. She did say that her family was thinking about sending some herbal remedies from China after she had this, but she hasn't taken anything. No history of sudden cardiac death in the family. No syncope. No dizziness, and no chest pain. Illicit drug use? Nope. She says she's allergic to ethanol. Recent weight changes, there were none. And dietary changes, no. She actually, when we saw her, she was sitting at the bedside with a ton of different food. She had pizza and Chinese food, all ordered to her. Yeah, the palpitations were only post-exertion on this one episode. I could go into the full review of systems next, but yeah, palpitation. Tomo asks, is it tachycardia, irregular, Brady? We'll get into that, but it was just sinus tach, and it was a regular rate. Sorry, regular rhythm. So a little bit of background. She's never had any medical or surgical history. Her mother has, she said, some history of thyroid disease. She's not sure what, and if she takes any medications for that. She has a twin brother. He goes to UC Berkeley, and he's healthy with no past medical history, not on any medications. Some social history. She's a sophomore at Columbia, from China. She came over about a year ago. When she started freshman year, there was some COVID problems. I don't know exactly how long she started in person. No history of tobacco use, alcohol use, or illicit substance use. She doesn't take any medications, and she said that she was allergic to just alcohol. No increased urination. I didn't ask that, but we didn't hear anything about increased urination after the event or when she was here. So full review of systems. It's positive for the chest palpitations. It was hard to kind of figure out what she meant. It was by the palpitation. Sometimes she said it was maybe chest pain, maybe a chest palpitation, but it was after she exerted herself on a 30-minute swim. She also noted some heat intolerance. In this time in January, it was like those days where it was frigid. She noticed herself actually sleeping with the windows open. And her roommates being really cold when she was hot. She noticed some anxiety over the past few months, 1 to 2 months, but she attributed it to being in college and being a student. She is not on an OCP. Archana, good question.
What makes you ask that, Archana?
For potential like PEs and stuff, so you can have palpitations or.
Sure.
Yeah, good question. And negative for active chest pain, fatigue, weight loss, changes in vision, eye pain. These are questions that she answered no to. No neck swelling, no fevers, chills, recent illness, hair loss, abdominal pain, nausea, vomiting, constipation, or diarrhea. Pregnancy, we got a UPreg and it was negative. Fatma, good question. Lightheadedness and dizziness, no, Athena, none of that. And was she overweight at some point? And does she take any supplements? No supplements, Chris. And I didn't ask if she had any, like what her weight was in the past, but she did mention that she didn't have any food insecurity or eating disorders. Energy drinks? No, she does drink coffee here and there when she studies, but no, none of the Monster or Red Bulls. Yeah, Chris, she wasn't like using anything exogenously to lose weight. So I'm going to go into the ED physical exam. This is the physical exam that was published from the emergency room and what we got for sign out. It's basically completely benign other than the heart rate of 132. Afebrile. And her weight is about 120 pounds. But yeah, other than that, no acute distress, just with some tachycardia on the cardiovascular exam. So now I'm gonna ask you guys if you have any further thoughts, anything that we might not have touched base on. And if you're doing the physical exam, where would you focus your physical? And maybe we could go into your thoughts and what you think about a differential diagnosis.
I just want to ask a question. So what's the pattern of her like periods before? Was it regular? Did she had any problem with her like periods before?
Before August of 2021, she was regular period. She said that she would menses would occur for about 3 to 4 days, and she wouldn't be a heavy bleeder.
Okay. And did she lose weight since like the past like 6 months?
No weight loss in the last 6 months.
Any abnormal hair pattern?
No. I'm just looking in the chat.
So it seems like people are most interested in like looking at the eyes, doing a thyroid exam, cardiovascular exam. Archana wants some orthostatic vitals. I guess like what would your guys' differentials be at this point? And also I guess what kind of preliminary workup would you be thinking about ordering, like if you get this patient in the ED?
Going through some of these questions here, Jonathan asked about a BMI. It's over 18.5, Jonathan. They didn't do a height on her, but her weight was 120 pounds, and she was, like, when I stood next to her, about 5'6", 5'5". So normal BMI. Good. I like, David, where you're thinking. A thyroid exam, shearing, same thing. Neck exam, montage, same thing. Rohit, all on point. Tomo echoes it as well. Archana, good question. We did not do orthostatics on her. We looking back at it, should have. But when I go into the physical, we can discuss why we did certain things. Montage, I like where your head's at. Javier, good with the UTOX. Anxiety score, Noor, good. All these I think are totally on point. Thyroid function, EKG, perfect. Everybody's pretty much on point. Jackie, should I go to the next slide here?
Yeah, that would be great.
So where we were thinking when we saw this patient, exactly kind of what everybody is echoing, maybe some hyperthyroidism given her family history, given her age, and being in college, maybe possible substance use or supplement use, panic attacks, possible anemia down on the differential, but a lot of things can be causing just a tachycardia. So we can go over the differentials and a more focused exam and where that kind of led us. So on the physical exam here, when we saw this patient, her heart was in the 130s. She had gotten 2 liters of fluid in the ED. Young female, we saw her positives where she was definitely a little anxious. She was speaking pretty quickly. I would say like a rushed speech. Couldn't appreciate any eye abnormalities. She did have a goiter that was present. Was not tender to palpation. Had a bruit, actually, which was kind of neat. Tachycardic on exam was regular rhythm. And then when we asked her to extend her arm, she did have a slight tremor on exam. Just gonna open the chat. Yeah, montage mania too. Everything's possible. So on assessment, basically we have like a young female, no significant past medical history. She came into the ED from the health center for workup of acute tachycardia. In the ED, she was persistently tachycardic despite fluid resuscitation with a slight tremor and goiter on exam, concerning for thyroid toxicosis. So the initial labs that were sent by the ED were pretty pristine. From the hematological standpoint, D-dimer was negative, which we could get into later, but which is very reassuring. Biochemistry was unremarkable. UTOX was negative. Beta HCG was negative. Urinalysis unremarkable, and her COVID was also negative. Any questions, if anybody has at any time, just chat them or shout them out. So going along with the routine workup in the ED, we got an ED got an EKG. Didn't show anything too significant, just some sinus tach. Albumin, Patrick, was like a touch low. I think 3.4 or 3.5 is the lower limit of normal. So technically her albumin is a little low, but she didn't look malnourished. And when we look into her liver enzymes, I wasn't too concerned. And then a chest x-ray as part of the routine workup also was unremarkable. So now what we got after we spoke to the patient, what everybody was kind of thinking, the thyroid labs showed a TSH that was almost undetectable, going up this way. Free thyroxine, which was elevated. T4 also elevated. T3 was highest I think ever seen it, with a free T3 of that was also off the charts. Later, we sent some antibodies that came back positive. It took a little while, but the TSH receptor antibody came back at around 38 for reference. 0 to like 1.75 international units is the normal. So that was pretty impressive. And then a thyroid ultrasound, which was actually done overnight, showed some thyromegaly with hypervascularity consistent with Graves. Just reading this part of the ultrasound, it didn't seem too impressive. For the normal size of the lobes, they were increased. The normal is here, 4.4 to 4.8 by 1 to 1.8 by 0.8 to 1.6. So the left and right lobes were both increased. And just in the impression is where they mentioned the hypervascularity. They didn't mention it in the report here. So diagnosis at this point was thyrotoxicosis secondary to Graves, which pretty much everybody was kind of hinting at. Does anyone have any questions about the workup or what was done? I'm going to go into a little more of a teaching about hyperthyroidism next. So yeah, just let me know if there's any questions.
Peter, I just have a question. Why was this patient admitted?
That's another great question. So she had tachycardia. That was when she was being admitted. The thyroid function tests were still pending. So she was in the ED and they weren't sure what to do with her. So at that point, she was admitted for further workup of tachycardia.
But she can't like follow up as an outpatient. I mean, she's not unstable and she's young.
I know. It's a good question. I feel like we have this question with a decent amount of patients, but we did calculate the Birch Wartofsky score. She was, I think her score was around 20. It wasn't too impressive. So I think it was just to be on the safe side. She was admitted to expedite a workup with endocrine in the morning.
And I guess when she's coming into the ED, you have this like unexplained tachycardia in a young person, which is always concerning unless you know exactly where it's coming from. So I guess having the TFTs come back like later that day or the next day kind of made it maybe more straightforward to manage outpatient. But I think if it's like 130s, 140s sustained and you don't clearly know what's going on, it's hard to feel comfortable discharging those patients then, I think, from the ED.
Yeah, for sure. And then Marta asked, did she get any treatment up to this point? So good question, Marta. I'll get into what we treated her with and what endocrine had recommended the next day. But overnight, when we saw her, her heart rate was in the 130s. If she was in the 140s, that would be a little concerning on that Birch Wartofsky scale for thyroid storm. But she was in the 130s. So we titrated her on propanolol. We gave her propanolol. I believe it was 60 milligrams Q6 hours. And over the next day, we got her heart rate, or the teams got her heart rate down below 100. So for the discussion, I wanted to talk about just hyperthyroidism, workup, treatment, everything about it as much as we can in the time left in the outpatient setting, just because it's a very common thing and it's commonly tested on the board. So just starting from the beginning, hyperthyroidism is just an excess of thyroid hormone, whether it's from the increased synthesis of thyroid hormones in like something as in Graves, a toxic goiter, an adenoma, versus a thyroiditis, or even an exogenous source. And the mainstay is first measuring the TSH, and then taking it from there, measuring the T4 levels, and going down this algorithm. If the T4 is high as well as an elevated TSH, we kind of have our diagnosis in the setting of an adenoma, or a pituitary, like a central hyperthyroidism. But with a suppressed TSH and a high T4 or thyroid hormone, we can do a radioactive iodine scan, which I'll go through in the next slide. So the diagnostic workup, once we see the TSH being low with an elevated T4, you could do the radioactive iodine scan, where if it shows low uptake, we have a few differentials: thyroiditis, ectopic thyroid hormone, and then exogenous thyroid hormone, or high uptake being something like a homogeneous radioactive iodine that which has a homogeneous radioactive iodine distribution in Graves, and then in a nodular radio distribution, we could have an adenoma or a toxic multinodular goiter. In the setting of this patient, just taking it back to the case, initial measurement of antibodies, such as the TSH receptor antibodies, could be a cost-effective approach for diagnosing Graves. And then on top of that, if there is high suspicion, given family history, given the setting, a radioactive iodine scan could be done if the antibodies are negative. And it's not normally indicated to do a thyroid ultrasound, but being inpatient, it was something that we had ordered because of the bruit on physical exam. So indications for imaging, and what the imaging might look like in the thyroid ultrasound. this is someone with Graves' disease. You have the hypervascularity present. And I always confuse this, so I wanted to just make a note of it. In a radioactive iodine uptake scan, what the difference between a cold and a hot nodule is. A hot nodule being something that takes up iodine, and a cold nodule being something that doesn't take up the iodine. In thyroiditis, we see a less than 5% iodine uptake, whereas in Graves, we see a diffuse goiter. The toxic multinodular goiter has both hot and cold distribution, and then this autonomous nodule shows that there's suppression of one of the glands. There are 4 mainstays of management of hyperthyroidism. The first being beta blockade, second being the Phyonamides, PTU, and methimazole, followed by radioactive iodine ablation, and the last step in that could be surgery. So medications, beta blockade, which beta blocker to choose. So we want to contain the heart rate. This young girl was in the 130s. So we decided to start propanolol because it acts as a twofer for blocking conversion from the T4 to T3. You could start at 40 to 60 milligrams Q6, Q4 or Q6 PO. And if IV, just 1 mg over 10 minutes, then 1 to 2 mgs every 2 to 4 hours for rate control. Going back to, I think it was Noor's question about why she was admitted. It's better to keep her on a PO med as opposed to starting on an IV med, converting it back to a PO med. So just in keeping that in mind, we had her on PO propanolol overnight. But as with medicine, everything's kind of, we've taken into account the big picture. She was 19, no other comorbidities, but patients with CHF, you might want to take into account either starting metoprolol or Coreg, or possibly not if they're in an acute exacerbation. I think it just depends on their hemodynamic stability and where they stand. But all beta blockers are pretty much one of the first steps to control the heart rate.
Peter, a question with the beta blockers. She was a swimmer, so for her next swimming session, and she's like on a beta blockade, if she actually needs to like increase her heart rate to actually swim, is that gonna be an issue for her in the future? That's something that while she's like on the thyrotoxicosis, you don't think about that. Yeah.
So I mean, from an inpatient standpoint, that's where our thought was to just bring the heart rate down to something manageable. But that is a good point. You know, we could titrate it from an outpatient standpoint. I will say that close follow up with endocrine and a PCP to make sure that her heart rate is where it needs to be is important. But that is a good question. I'm actually not sure offhand how that would work.
And hopefully from an outpatient point of view, she shouldn't be on the beta blocker for too long because she's a young female. So we're looking at a matter of weeks that she'll be on the beta blocker, not months.
All right, thank you.
All right, thanks, Javier. Good question. And now going into the Phyonamides, just some important points about each of them before we initiate them. The methimazole and the PTU. We want to check a CBC with diff because there's risks of agranulocytosis and also liver damage with these drugs. So we want to get a baseline. Methimazole has a longer duration of action with a lower incidence of side effects. So of the two, you would want to start the methimazole, but in patients that are in their first trimester of pregnancy and patients that have adverse reactions to methimazole that do not wish to undergo radioactive iodine or surgical management, we can initiate the PTU. So titrating these meds, we want to obtain a free T4 and T3 4 weeks after they start, followed by 4 to 8 weeks with each dose adjustment. And then after normalization, you want to monitor 3 months. We could continue the thionamide thereafter for 12 to 18 months. And then once we can discontinue, once thyroid function normalizes, you want to monitor thyroid function every 1 to 3 months for up to a 6-month period, 6 months to 1 year period. And it's important to talk to the patients, and if they have recurrence of any of their symptoms, to follow back up with their PCP or with the endocrinologist. And the next step in treatment would be the radioactive iodine ablation. Indications for this are patients who can't be controlled on thionamides for compliance or tolerance issues. Don't want to start, we don't want to do this in patients who are pregnant or also have moderate to severe orbitopathy like exophthalmos. And for medication management, peri-ablation, we want to discontinue the thionamide at least 5 days before and restart 3 to 5 days post-procedure, as an effect that the ablation can take up to 12 weeks to work. And then 4 to 8 weeks post-ablation, we'll measure thyroid hormones because people will develop hypothyroidism and require the opposite with thyroid supplementation. And the last step in the treatment could be a thyroidectomy. So indications for this are patients that have failed prior options or have contraindications to the radioactive iodine ablation or thionamides, patients with excessive large goiters with compressive symptoms, patients with concern for thyroid cancer, moderate to severe orbitopathy, and also pregnant women. There haven't been a ton of studies that show why, thyroidectomy versus the radioactive iodine scan. But something I found that was interesting was the median time for the thyrotropin receptor antibodies to decrease after Graves treatment. And it takes almost a little more than 2 times the amount of time after radioactive iodine therapy compared to the thyroidectomy. So patients that have these compressive symptoms and the orbitopathy to try and get everything under control as soon as possible. So how are we on time? I had a few questions because hyperthyroidism is a big topic. I wanted to just go over a few questions that can encompass some other causes of hyperthyroidism. Jackie, is it okay if we go over these? Do we have time?
Yeah, of course.
Okay. Oh. So first question. We have a young woman, 25. She's being evaluated for anterior neck pain, fatigue, exercise intolerance, excessive sweating, and tremors that began 6 weeks ago. She had other than an upper respiratory infection 2 months ago. She's been healthy. Medical history is otherwise unremarkable, and she takes no medications. Physical exam, notable for a heart rate of 105. Normal vitals otherwise. Patient's thyroid gland is tender to palpation and is without discrete nodules. No thyroid bruit is auscultated. Bilateral lid lag is noted, but there's no proptosis, conjunctival injection, or chemosis. There is a fine tremor of her outstretched hands, and she has some brisk deep tendon reflexes. Lab work is done showing a TSH that's unremarkable, a free T4 level of 2.8 and a serum T3 of 190. She has a negative urine pregnancy test. So the question is, which of the following is the most likely diagnosis? Does anyone want to give it a shot?
C.
Nice. Was that Noor?
Yeah.
Nice work. Yeah, everybody's in the ballpark with that. So it's the key to this, the hallmark of subacute thyroiditis is that there's a tender and painful thyroid. The TSH is suppressed with an increased T4. To diagnose this, we can do a radioactive iodine scan that will show a low uptake of less than 10%. Keys to this question were the fact that she's presenting post-URI and she has, like we said earlier, the painful gland. Thyrotoxicosis in both Graves and in nodular thyroid disease, those present with painless thyroid glands. So that's the distinction. And the nodular thyroid disease will mention, if that was the answer, it would have mentioned something about a nodular gland as the pathology says, which she did not have. Next question. Does anyone want to read this, or I could take it? So we got
Patrick wants to work on his pronunciation, so maybe he can.
29-year-old woman is seen in follow-up for evaluation of abnormal thyroid laboratory results. How's that? She is currently 26 weeks pregnant. She was originally evaluated 1 week ago for concerns about lack of weight gain during pregnancy, palpitations, anxiety, and insomnia. There is no family history of thyroid or autoimmune disease. Medical history is unremarkable, and her only medication is a prenatal vitamin or vitamin. On physical exam, other than a pulse rate of 98 beats a minute, vital signs are normal. The patient is a thin, gravid woman with a mild tremor of the outstretched hands, lid lag, and a small goiter. There is no exophthalmos. Laboratory results obtained last week show a thyroid stimulating hormone level of 6.5, I think it's microunits per milliliter, and a free thyroxine level of 2.6 nanograms per deciliter.
So the question, diagnosis again. Does anyone want to take a stab?
So anyone want to post in the chat if you think A, B, C, D? Or also unmute yourselves.
B.
So she had an increase in T4 as well as a normal or increased TSH.
Maybe if we go back to the question, I think people are looking maybe to see the TFTs now that they know the question.
Oh, it's D because the TSH is elevated. Sorry.
Yeah, it's a thyroid stimulating hormone secreting adenoma, and this we could figure out based on the labs. Basically, in gestational thyrotoxicosis, we'll have a decrease in TSH with an increase in T4. Graves, same thing, decreased TSH with an increased T4. And hypothyroidism, she has the opposite symptoms. All right, last one.
Tomo, do you want to help us out? As it may be one of the last times we can rope you in?
Sure. Okay, so a 68-year-old man is evaluated in the office for increasing shortness of breath, palpitations, difficulty sleeping, fatigue, generalized weakness, and 4.5 kilogram weight loss, but less. over the past month. His medical history is significant for heart failure and atrial fibrillation. For the past 2 years, his medications have been metoprolol, lisinopril, amiodarone, and dabigatran. On physical examination, the patient is a febrile blood pressure is 140/80, pulse is 102, and respiration rate is 24. Deep tendon reflexes are brisk and symmetric. A fine tremor of his outstretched hands, bilateral lead lag, and an irregular heart rhythm are noted. Examination of the thyroid gland and remainder of the physical examination are normal. Lab studies showed a serum thyroid stimulating hormone level less than 0.01, a free thyroxine level of 3.1, and serum total thyroidine level of 190, and TSH receptor antibodies are undetectable. Other laboratory studies are normal. So on thyroid ultrasound, the thyroid lobes and isthmus are normal in size. No thyroid nodules are seen. The background thyroid parenchyma demonstrates no demonstrable vascularity on color flow Doppler. Chest radiograph is normal.
Thanks, Tomo. So in addition to increasing the metoprolol dose, which of the following is the most appropriate initial management?
Is it A?
I think like if it is continued at amiodarone, like the half-life is so long that I don't know how much is it going to do. But
yeah, I was between A and D as well. Sorry, A and C. So what's going on here is amiodarone-induced thyrotoxicosis. And like Chris is saying, the half-life of amiodarone is so high, or takes so long to clear, that the treatment of thyrotoxicosis in this setting would be to begin the pred. And just something I learned after this question was there's a type 1 and type 2 amiodarone-induced thyrotoxicosis. A type 1 being thyrotoxicosis with an underlying goiter or latent Graves' disease. The key for that would be to discontinue the amiodarone and then initiate methimazole. But the treatment of type 2, which would be what he is someone without thyroid disease, where a moderate to high dose of prednisone tapered for 1 to 3 months would be the treatment. And the reason why we wouldn't discontinue the amio is because of the long half-life. And succinctography, Patrick might need your help on pronunciation. Scintigraphy is not indicated because amiodarone has a high amount of iodine in it, and the levels can skew up any of the studies. So right now, it wouldn't be something that we would do. So treatment of type 2 destructive, this is considered destructive thyroiditis, would be initiation of a steroid. So just going back to the case to finish up, she was started on propranolol 60 milligrams Q8 hours instead of the Q6 that I mentioned earlier. And she was initiated on methimazole 30 milligrams daily while inpatient. She was only inpatient for 2 days. Endo was consulted. They spoke to her about the risks of agranulocytosis and hepatic dysfunction. And they also spoke to her about the need for contraception given the teratogenicity of the drug. And she actually has an appointment with Dr. Bernstein on the 23rd. So sometime next week if anyone is in endo clinic. So yeah, that's about it. Does anyone have any questions?